get started.
Fantastic. Thanks so much, Dave. And we also need to thank my wife, Jen. She is looking after our 4-year-old downstairs and making sure that he doesn't barge in, which he has done many times, including on media interviews like that guy in in Korea. So in the interest of time, I'm really, really honored to chair this panel of literally some of the leading voices on various aspects of COVID-19 today. I really can't think of a more extraordinary set of people to talk us through some of the big issues from a health point of view, policy point of view, from a first-line provider point of view. Is really extraordinary. I know that some panelists have to leave quite soon, so I'm going to start with Mark, who just joined, Mark McClellan. Mark, let's start with you, and let's start here in the United States, which is very sadly, arguably the center right now, the epicenter of this global pandemic. You recently co-authored a paper with Scott Gottlieb, other colleagues from AEI, and other authors. It was called A Roadmap to Reopening. And it is widely reported that although President Trump wanted to open up America by April, there were a few papers that stopped him. Yours was one. I know that the models from the Institute for Health Metrics and Evaluation, that was another. You helped to convince him to extend, I think, the federal lockdown until the end of April. And then you've argued that we could start to perhaps open up the US. Can you talk the board and our guests through the key steps in your very influential roadmap?
Yeah, Gavin, I'm glad to do that. And I also just want to say thanks to the Global Health Institute. You all have been out there on so many aspects of COVID-19 management and response, been excellent collaborators for the kinds of issues that I'm about to talk about for the US. Every country is facing these same issues in one way or another. And if it wasn't clear before that health policy matters, if it wasn't clear before that we're all connected globally, well, it's very clear now in terms of how we need to move forward in responding to the COVID-19 pandemic. Here in the US, it's hopefully about as bad as it's gonna get, at least in some parts of the country. It's a horrible week in places like New York, others headed in the same direction towards peak cases, Detroit, New Orleans, where so far, I think the good news is that we are at capacity in a rapidly expanded, adjusted healthcare system that is struggling to keep up with this phase of the epidemic, still having shortages of masks, still having shortages of other critical supplies like ventilators, but you've seen some very creative responses locally and a national response start to kick in. Steps like sharing ventilators, bringing them over from veterinary facilities, adapting other kinds of devices, and healthcare providers on the front line that are taking amazing steps to try to work under these challenging conditions. And my hope is that we are going to be able to get through these next few very tough weeks without having the same kinds of excess demand problems like we've seen in other parts of the world already, Italy and elsewhere. It is not pretty. It is a horrible situation, but the healthcare system here is starting to respond. The work that Gavin mentioned begins to look beyond this phase. So lots of things that we need to do now for surge capacity and for taking extreme physical isolation measures to bend the curve of new cases when we don't have anything else to offer. But that's going to change. So we've highlighted in our work ways of accelerating progress in several key areas. One of them is in the development of better diagnostic testing, and that's coming. The US has been short, but if you look at test production now, it's really come up for the diagnostic tests. We haven't yet worked out logistically how to get all the tests and all the supplies to everywhere they're needed, but we're getting much closer to that. We're also starting to make progress on the therapeutics. That's really the whole ballgame here. Eventually, we are, I think, going to have multiple vaccines that could be effective against the virus, and you're seeing an unprecedented set of activities around the globe to accelerate production, including some steps that we've been advocating since the start, like making commitments for large-scale production at the same time as you're doing the vaccine testing. So there's literally no wait between demonstrating the vaccine is safe and effective, and that is a significant, and even under the best of circumstances, time-consuming effort, and then making it widely available, not just in the United States and a few developed countries that have the money, but through a real global program. The Wellcome Trust came out with a report just recently on this topic too, about what it's really going to take to control this epidemic for good. And I hope we get a chance to talk more about that. But unfortunately, we're not there yet. That's a long road between where we are today, hopefully getting through this surge of cases in the US and other countries, and getting to the point where we can return to life that's more normal. We call that phase 3 in our report. Between where we are now, phase 1 and phase 3, when we have a vaccine widely available and immunity widely available, there's a challenging phase 2 process where we outline the steps that we think need to happen. It's not a specific date, it's a set of key conditions for significantly more reopening to occur. We have a new report out this morning with some of my same collaborators with the Duke Margolis Center, Scott Gottlieb, another former FDA commissioner who's been very engaged on these issues, as well as experts in the US in epidemiology, in the medical device industry, and in pandemic preparedness from Johns Hopkins. And that lays out a very specific national COVID-19 surveillance plan so that we can do rapid testing and move from this reactive phase to being very proactive and identifying local outbreaks when they do occur, tamping them down quickly, taking other steps to monitor for asymptomatic spread. This is a significant undertaking, but we think it's really important in the next few months to enable steps back from the extreme social isolation measures that we're taking now, so that especially by fall, when there is, I think, a significant chance of a further epidemic wave, and even before fall, when there are pockets around the country, it doesn't take much for this virus to spread, we can have more confidence that we are never, ever going to have a situation like what we're living through right now. The other key piece of this over the next few months is other types of medical treatments, and we outline in our report some steps that can be taken to, if not prevent the infection with COVID-19, at least through antivirals or some very promising immune-based therapies to tamp down the severity of infections and maybe provide some prophylaxis, some help for people like healthcare workers who are in harm's way for being more protected against the virus. Those steps too can reduce the burden of the disease and the likelihood of its spread. There are a number of specific policy steps that the US has started to take in this direction. Again, there are many more that we've laid out. This is a significant effort, and it's probably not going to be life back to normal in the coming months. It's a new normal of more distancing, face masks, other steps like that, but ones that can enable most of our economy to come back if we handle these issues effectively. And other countries need to go through the same kinds of steps. Where we're particularly concerned and hope to do more work with the Global Health Institute is around what is that pathway between where we are now and the vaccine for other lower and middle income countries, where getting this kind of diagnostic capacity in place is more challenging. We're getting interim treatments that make a difference available can be more challenging, but again, critical issues for dealing with this pandemic over the coming year.
Thanks, Mark. I think that's right. I mean, I think that this is clearly a time for global solidarity, and it's probably a time when the governments of all nations need to come together in an unprecedented way to form some kind of a global purchasers club where perhaps you pay according to your means, you create a pool of these tools, diagnostics, vaccines, etc., and then allocate them in a way, that is fair, transparent, and goes to the countries that need them the most. I have a piece coming out on this shortly. Can I ask you two quick follow-up questions that I think are related? I think you're suggesting then that the next few months here in the US, we need to kind of figure out who has the infection, who is potentially immune, who is uninfected. And then according to that, we can say, okay, well, you could potentially go back to work. You need to remain isolated. You still need to be quarantined. But for that, we're going to need to do better on testing, on understanding who's immune, and also on contact tracing. And I'm not sure we're really there yet on any of those pieces. Is that right?
That's right. No state, no region has fully established the capabilities that are needed for an effective COVID-19 surveillance system. So I want to make a distinction between two types of testing that are important. One is these molecular tests for the virus that you've been hearing about have been in shortage, and in some places like California taking a long time for the results to come back. That capacity really is ramping up, and we've seen a lot of very promising innovation to move from tests that you have to send off for a lab and takes hours to days to get back to so-called point of care tests that can be done right in a facility with results available in a few hours to maybe a few minutes. We're also seeing some innovation in how tests are done, away from tests that have to be administered by a health professional and all the protective equipment to tests that people may be able to do themselves. And that capacity is ramping up rapidly in the United States. As I said, there's some logistical issues in getting the tests and the supporting equipment to pop-up locations or drive-throughs where people can get these tests easily in the community, but there are models for that now, and they're models that we think need to be scaled really rapidly. Excuse me, there's a second kind, excuse me, of testing that is, as you said, for previous exposure and immunity to COVID-19. Those tests are not as far along. We're starting to do those kinds of serology tests. They're really easy tests in principle to do on the blood to see who's been exposed. And we should know soon, again, this is part of our recommendations in communities around the country, just how widespread COVID-19 has been. It may be relatively prevalent, and by relatively prevalent, I still think under 10% in some regions of the country, less so in others that have been lucky enough not to have as big of outbreaks lately. But that's a very important baseline for knowing how protected each community is against further outbreaks of the infection. What we don't quite have yet is tests that can be done to determine with a lot of confidence whether someone really is immune or not. We don't fully understand the immunologic properties of the virus. If you have a very mild case, are you immune? If you are immune, how long does it last? That's an area for very important applied research that should be doable right now and very quickly. So that's an important element as well. And the third piece of this is building this into a more integrated, enhanced public health system that can track, sort of like you track the weather, what's going on in cases in each region in a very timely way and make very good, accurate predictions using the testing data that I just described, and also other technologically enabled sources of data, maybe how people are moving around from anonymized cell phone data. We've seen interesting reports using temperature that's reported online, things like that. Integrate those pieces into a prediction and response capability. So when these outbreaks occur, and they will continue to occur, can we rapidly go in, identify who's been affected, identify most of their contacts, if not all of their contacts, and take quick steps for isolation, quarantine, and again, rapid testing, not testing that takes weeks, but testing that can be done quickly. Those kinds of steps effectively let you locally put in place really quickly some more isolation, very focused isolation. So you're effectively driving down, for those of you who follow this stuff now, the R0, the ability of a virus to spread from person to person without having to impose nearly as restrictive measures on everybody else. So again, not back to normal, but a very feasible surveillance system with some significant investments and a new kind of collaboration between the public health community, medical care providers who will do this testing and help with the management and response in the community, and all of this technologically enabled. That's what 21st century public health should look like here and everywhere. And hopefully this pandemic will be a good push to get the whole world to get there.
Thanks, Mark. And obviously, Margolis Health Policy Center has really been at that interface for so many years, and you're so well placed. I think that in addition to hanging on Tony Fauci's every word, I think Americans are hanging on to your every word and Scott Gottlieb's every word. So thank you. Our neighbor bought a puppy and named it Fauci. So I think there might be some puppies named McClellan pretty soon as
I don't
well.
know about that, but
So on to someone else who's really been.
Gavin, we have
Yes.
time before Mark leaves us for a couple questions of him.
Oh, Mark, what time do you have to leave?
I've got another 11 minutes.
Oh, okay, good idea, good idea. Thanks for suggesting that. So I'll just open it up to questions for you, Mark, right now, rather than we were going to open it up to questions at the very end. So let's do that. That's a great idea.
Thanks, Gavin. Hi, Mark. It's Elaine Leavenworth.
Hi, Elaine.
Hey, you were talking about the surveillance, and it seems to me that it's really chaotic, and I'm sure you know better from the front lines here. I was watching yesterday Governor Northam's press conference here. I'm based in DC right now, sheltering, and his health person said they're not, when asked, because they were reporting their data for the day, and when asked by one of the reporters, they actually wanted to know the data they had on recovered patients, looking for a silver lining, with all the negative, sad news. And he literally just stood up there and said, "Oh, we're not tracking that." Yeah. And I'm like, your head explodes, right? And so I guess the question underlying all of this is how are you seeing a path toward improving this surveillance process? Because clearly all of what you're talking about is dependent on this. Because we're not going to find those patients with any form of immunity. We're not going to be able to track and build this better system if we don't create a superior surveillance network. So who's the leader, and how are we going to teach these states, et cetera, et cetera? What do you see here as the pathway?
Yeah, Elaine, like I said, we're not there yet. And we are, Scott and I and our collaborators and the Duke Margolis Center have a big effort underway starting this morning when we just released this, a new report on a national COVID-19 surveillance system, what it's going to take to achieve containment of COVID-19 in the United States. And it includes all those elements that I just described. Yeah. The good news is there are some states and some regions that are taking, I would say, pilot steps in this direction. So Duke is launching a local track and trace capacity using some Duke health staff. I think this is actually a good opportunity for young people who care about health to, it takes some training to be a good contact tracer, a good part of this rapid response team, but not a huge amount, some good interpersonal skills and so forth. So I think there's some job opportunities here. Along with the pilots that are taking place at places like Duke and in Washington State, Maryland's working on this too. It is going to take congressional action, so there need to be some significant resources. We think through the Centers for Disease Control, they should be the manager of this national system, but in partnership with states.
Do you really think it's a government? I mean, do you?
I think there's some government resources needed to support a public-private collaboration to get the tests that are needed everywhere around the country locally, so that people can get rapid testing and then contact tracing everyone with symptoms. Some people who are high risk without symptoms, and we go through those categories too, should be able to get rapid access to testing. There's a component of this on the healthcare side because the healthcare providers are doing most of the testing now. They're doing testing, but we're still in most cases getting reports back by daily update, spreadsheets being sent by email or even phone notification. There are electronic standards that should enable that kind of test notification to happen automatically off of electronic records, off of laboratory electronic reporting and payment systems. So yeah, you're right. There's some more infrastructure that needs to be put in place. It needs to be a public-private partnership that reaches each local community, but that's supported by the federal government, CDC, and some payments to healthcare providers help us build a new healthcare system that does a much better job of public health surveillance. But we think those are good investments for the long term and absolutely critical to make now and in the coming weeks as we come down from this surge and prepare for what could be a big wave again seasonally in the fall and outbreaks in the meantime.
Yeah. I look at this and I think it's almost like the EMR companies or something. We've got to figure this out. Otherwise, we're going to create another layer of challenge on an already stressed CDC that obviously had challenges already. So I just keep thinking, where in the private sector can we go that has, you know, we have this sector that has a lot of capabilities. Now, trust me, there's a lot of concern I have around privacy and those issues that you well know. So anyway, I'm just trying to think outside the box as to how we can get this done.
That's what we need to do. And I think this is not a 20th century public health system that we're aiming for. We're aiming for CDC and state public health agencies is coordinating the data, but relying on a lot of input, as you said, from technology, from private sector sources of information, and from partnerships with healthcare providers on the front lines. This is doable. There are other countries that have they started from different places, they've taken similar steps, and it's something that this country really needs, again, so that something like this never happens again.
I just say call Tim Cook, because they're not in the data business. Well, they're not in the data business, but they know how to collect. I mean, they know how to do things, and so they would have
those apps connecting people to tests are going to be really important.
Anyway, thank you, and thanks for all your continued work here. I know it's critical, and I hope you're also getting the FDA to move faster. You and Scott have written some great stuff that I think pushed them.
Thanks.
Hey, Mark,
any other questions for Mark?
Well, just a really quick question, which may seem a little bit out of left field, but actually we got approached by, speaking of those apps, by Google and some other pretty legitimate players in the last few days about doing an online smell COVID campaign. I don't know if you've heard of this, but because of the, losing smell or taste, which happens, I guess, with so many viruses, but there's talk about having, folks do a smell test and report online. They were trying to enlist us on it, and frankly, I put a stop to it because I worry that it could have other consequences, and we couldn't get anyone from CDC or anyone else to say this makes sense. But have you heard of this?
Well, anosmia definitely is a commonly reported symptom. I think that the best approach for apps along the lines we were just talking about with Elaine is having apps that help people screen through the usual set of symptoms and then are connected to their healthcare provider and a way for them to get a lab test based on that. So Apple is working on an app, and so are lots of other people that tries to take account of these different, the whole set of symptoms. Temperature checks can be an important signal, especially if in conjunction with some of the other symptoms that go along with early stages of the viral infection. And those kinds of apps, maybe not focusing just on smell, but those kinds of apps will get better over time. You're going to get more data on, and that's why the testing and sharing the data from the test electronically is so important. So that's the big data that's going to get us to some really efficient apps and supporting technologies to identify cases early and be able to respond to them. So I don't know about smell by itself, but this notion of reaching people personally with supporting technologies at home so they can, so that they'll know when to self-isolate, that regularly may end up being a part of the new normal for a while, and certainly if you go to a higher risk workplace. But that technology is exactly what we need to link to the testing capacity and help us identify outbreaks early and contain them.
Yeah.
I have a question. With regard to the immunity, both the strength of the immunity and the length of the immunity, is there any way to model this or to extrapolate from other coronaviruses to get a sense of how much protection there may well be?
Absolutely, and hopefully we'll get that information pretty soon. So from other coronaviruses, the news is somewhat good. As FDA commissioner for SARS, and this ended up being a useful part of our planning for the future too. It does look like for some of these other coronaviruses like SARS and MERS, if you mount a strong immune response, it lasts for a while. And for those viruses, people generally mounted strong immune responses because the reason they were so much easier to contain, even though they're so much more virulent, the outcomes are so much worse per patient than COVID-19, is that people had very severe symptoms when they started being contagious. So it was a very virulent virus, but one that generally gave a very strong immune response. In this case, we're just not sure yet. For all the people who had asymptomatic or minimally symptomatic infections, did they really mount a strong immune response? Even though they may not have even noticed they had the virus. We'd like to make sure that those responses do persist. I'm pretty hopeful that they'll at least get us through, for people who have been exposed, it'll at least get us through the fall potential big season again. I wouldn't be confident though yet that it's lasting long-term immunity and that people won't need some kind of booster vaccine or something like that. The first problem we have, though, is that we don't yet have reliably, widely available tests that are very validated quantitatively about just how much immunity you have. It's one thing to have a quick blood test to see, okay, who's been exposed? Is there some, evidence of, IgG, the immune globulins? It's another thing to really know, is that response, significant, and are we measuring it accurately as a basis for, say, some kind of certification that could let someone go back to work that could be applied at very large scale. That can be done in labs through ELISA assays. It's not yet widely available and proven for community-based large-scale testing. And in that report I mentioned, this is another element where we think when you do the research really fast, it's not that hard to do with enough people who have been exposed to COVID-19 to get those immune levels and have at least a very good idea about how immune people are. So that's another area for some important fast work over the next couple of months.
Thanks, Mark. I think, go ahead, Elizabeth.
No, I was just saying thank you, and thank you for your work.
And I think just a couple of things. One is, just one thing. I think Italy and, Germany, I think Italy and certainly the UK are all considering giving immune certificates to people. Yeah. It's a nice idea, but I agree with you, Mark, that it's a brave thing to do at this stage because we just don't know. I think that in the interest of time, I know that some of the other speakers have to go quite soon as well, that we are going to, thank you, Mark, we're going to move on to someone else who's been at the forefront, including of vaccine development efforts through the Duke Human Vaccine Initiative, that's Sallie Permar. So Sallie, I want to pivot now to children who seem to get a less severe disease, although there was a child who died in Britain. They did have some pre-existing health conditions. And I'm also interested in trying to understand what their role might be in transmission. So help us through those issues.
Yeah, so thank you again for having me on this panel and, representing both the health system and the vaccine effort. So hopefully I can answer some questions there. But one thing that I've really been impressed by with this pandemic, being a pediatric infectious disease specialist, is how little disease we're seeing in children. We're used to respiratory viruses, and especially, a brand new respiratory virus where there is no immunity in the human population, a sort of U-shaped curve in terms of disease severity with age, where young children are one of the most severely impacted population. And then there's also a severely impacted population at the upper age limit. And we're just not seeing that pattern. We're seeing a pattern of more, initially it was really thought disease in the elderly was the most severely impacted group. That's been moving down into the middle-age adult population, but still not seeing many cases that at least present for clinical care and certainly hospitalization in children. Now, as Gavin says, there have been some deaths reported. I believe there are 3 pediatric deaths reported, and that's throughout all nations. But again, and repeated in every nation that's reporting the severity and hospitalization rates, pediatrics is really under contributing to the numbers. And so that really raises some important questions about why is it that children who are certainly becoming infected with this virus, because we've seen that children can be infected, but they're not preventing with the severity of disease of that of adults. And so what is it that's different about children, either their susceptibility to maintain virus replication, or their immune response to this infection that is different from adults and really protecting them from severe disease? Because there are some real lessons here for vaccine development and even therapeutic development that we should continue to study.
So are there clues then from the protection that children seem to have that you at the Duke Human Vaccine Initiative or your colleagues elsewhere, I mean, I looked yesterday, there are 62 vaccine candidates around the world. The WHO is doing a nice job of tracking them. Are some of those efforts being guided by what we're learning in children?
Well, I think that we need to develop that data. So we need to both generate these biospecimen banks of children who are being infected, asymptomatically infected, as well as maybe symptomatically infected, and comparing that to adult populations. And certainly the Duke clinical research efforts are doing that. We are working towards collecting biospecimens from individuals who are diagnosed with the infection, and then not stopping there, but going and collecting biospecimens from all of their family members. So other people that are exposed to that infected individuals. And in fact, healthcare workers is going to be one of the main targets of those research studies, both because of the susceptibility of exposure there in healthcare population, but also their willingness to participate in research is generally high. And so, we certainly infections have been reported in children, and it's thought that it's not that children are not susceptible to becoming infected, but more that they seem to be protected from this severe disease, at least based on the data that we have. And so obtaining those biospecimens are really important to understanding what is the type of response to this infection that really contains it and prevents that severe disease, but also animal models. So animal models have been rapidly developing, and one area that I am involved in and have been impressed by is the non-human primate models, which we know can be highly relevant to the human situation, where several centers have initiated these models of infection in various non-human primate species and have developed a human-like disease in terms of the lung signs as well as the viral shedding. And so those are excellent opportunities to now look at various risk factors, including things like age, including things like risk factors like exposure to vaping or smoking that may be able to be modeled in non-human primates as well. And then, thinking about, we need to think early about who this vaccine is going to roll out to. I think, there's going to be initial safety testing in healthy adults who can consent to that safety testing, but and probably rolling out to the high risk group for severe disease will be important initially. But the way that you can obtain really high coverage of a vaccine is putting it into the pediatric schedule. We know that from our struggles with the HPV vaccine to get high coverage, and how the hepatitis B vaccine went from pretty poor coverage to very high coverage when it became a pediatric vaccine. And so can children make a good response to vaccines? If they can make a good lasting response to vaccines, they may be the best target, because not only would they that allow the generation of protective immunity prior to adolescent or adulthood, it also may address the spreading. So
that's very interesting, actually. I'm involved in various efforts to think through a fair global allocation. And to be honest, so much of the focus, as you've said, has been health workers first, places that still have a fire going on, a really bad epidemic, then the medically vulnerable, and then the general population. But you're saying that actually thinking of the schedule for children early might turn out to be an important strategy.
I do think so, because again, the history has just shown how adults and adolescents are not very good at showing up for vaccines,
Yes.
but it's very routine in the pediatric population. And this important strategy of really limiting the spread. And we don't have great data to say that children are, an important reservoir for infection, but I think there's a lot of suggestions that that may be the case, that children are certainly asymptomatic, so they're out there with the opportunity to spread the infection. There's virus certainly in stool. We know that a lot of diaper changing goes on by adults, that could be an important source. And their interactions through childcare and things like that. So I do think early on it's important to do the studies to show that can infants make a good response, or children make a good response similar to that of adults. And that's something we can model and are proposing in the non-human primate models now with some of the lead vaccine manufacturers. And can it also prevent infection there that will then limit the spreading to susceptible adults?
Thanks so much, Sallie. Hold your questions. We're going to have an open Q&A at the end. I want to get to Jono, who I know I think has to leave soon as well. Jono is the hardest working man right now in all sorts of ways, particularly show business. I've every time I turn on the television, there you are, and I say that with joy. It's fantastic to see you out there providing public information and just explaining what's going on in ways that the public can understand. So you wrote a book in 2018, The End of Epidemics, The Looming Threat to Humanity and How to Stop It. And there are so many quotes that ring true today. There's this one, which is really very striking. You wrote, "It's a dystopian nightmare and it could happen tomorrow. An uncontrollable pandemic overwhelms public health systems and wipes out millions of people in less than a year. Business and industry grind to a halt. Up to $3 trillion, a tenth of the country's GDP evaporates as fear of infection stifles travel, tourism, trade, financial institutions, employment, and entire supply chain." So here we are. You are obviously extremely prescient. You had laid out in that book, which you very kindly distributed far and wide across DGHI years ago when we first connected with you, 7 steps, you called them the power of 7 to end an epidemic before it begins. I am 100% sure you are going to write an updated version of that book. What is the updated version going to say?
It's chilling to go back and read some of those things. And I must say, it's one thing to sort of put it on paper, knowing that's a potential reality, but it's just so surrealistic to be living it. And so just a couple of words about how the book came to be. In the middle of the Ebola outbreak, as people were coming in West Africa in 2014, I kind of looked back and said, where will we be in 3 years from now? And I actually feared we would remain vulnerable. So I took a deep dive into the last 100 years of epidemics and wanted to pull out the lessons. And the book was written not for the techies in this area, but from what I'd seen from AIDS, that we need to make things digestible to the wider public. I think, and actually we are working on a refresh with both the US and the international publishers. And basically the 7 principles that we came out with really stick. And we'd add the successes and the failures of COVID and the lessons. But let me go through them point by point. Number 1, lead like the house is on fire. And that's so critical, is decisive, courageous, urgent leadership. In 1918, President Wilson was so focused on the end games of the war, he would not hear a word about the pandemic, not from the head of the military, not from his personal doctor. He wouldn't let government resources be used. So the US cities were on their own, and there was a 4-fold difference in the mortality rate among cities. And in a very unsettling way, we're almost in the same situation now, where each state is on its own, and a pandemic needs a whole of society, whole of country response, and that comes out even clearer. Another lesson we saw with SARS, the importance of decisive leadership on the part of the World Health Organization. One of the reasons why that coronavirus was put back in the box in 6 months, part of it was its own biology, part of it was decisive, rapid action. And I think that, at least on the part of the World Health Organization, that wasn't so good at Ebola, but it's really been strong now with coronavirus. The second thing, strong public health systems. We know now some are prepared, a lot weren't. What we have now, which we didn't even have six years ago, is a global scorecard. We know for 195 countries, in terms of the core parts, not only of prevent, detect, respond, but also health systems, risk environment. We know where those countries stand, and less than 1 out of 5 is well prepared. We also know that the score on paper does not necessarily predict performance, as we've seen here. On the other hand, Korea, which is a green at 70 out of 100 on the Global Health Security Index, did well. Iran, which is a bright red at 38, not ready. They didn't do so well. So that's number 2, is strong health systems. Number 3, active prevention. Hygiene, social distancing, we knew it worked, and we knew it worked then, we know it works now. The lessons from 1918 are holding again. Those cities and countries that begin earlier with their measures and keep them longer did better. Fourfold difference in the US, and a good part of that was explained by those differences in the speed of implementing those messages. The fourth element, we call it timely truths, basically communication with the right message and the right messenger. And the CDC, beginning in SARS, has developed and refined 6 principles for communication in public health emergencies. And I won't go through all of them, but just give a sense. Be first. Get your messages out there from the official sources first. Next of all, be right. Get the facts in line. Be credible. Say what we know, what we don't know. Express empathy. Tell people what they can do. Those messages are so clear. And the cost of dyssynchrony between the public health community and the elected leadership is the worst thing for a pandemic. We know it's got to be consistent. But we also have some great examples, even now, as we've had in the past, of mayors and governors who emulate the best of those. And actually, CDC teaches those lessons to our mayors. The other thing that we see over and over again in the issue of what we call timely truths and fatal fictions, the communication part, is, we've had all of the same kinds of conspiracy theories, blame, stigmatization that goes back to the Black Plague and even before that. And social media is a double-edged sword. In a way, it's a triple-edged sword because it's a way of getting out the correct messages. It is a way of understanding how people are misunderstanding so you can adjust, because good pandemic communication is not just getting out the correct messages about what to do, hand washing and all that, but also identifying common misbeliefs and countering those. But again, the problem with social media, of course, is the disinformation. The good news is that what this has done is it speed along the process of people like Facebook, which are working with 7 different fact checkers. And I didn't even realize the fact checkers have an international association of fact checkers that have standards for fact checking organizations. So we have this technology that is, we know how to work it technically, but developing the culture around this technology of social media in order to control it, that's just coming up. Number 5, innovation. We talk about the innovation process and how you have to adapt that innovation process during a pandemic. And we talk about, in the book, we talk about 5 potentially game-changing innovations. And I'll just talk about two of those, and we put budgets on those. One of them is point-of-care diagnostics. It became so clear. I mean, I could see it vividly. During the Ebola outbreak, I knew that they didn't need more, as one of our Sierra Leonean colleagues called it, overzealous helpers. So I didn't go out during the outbreak, but I went back around and visited places, going to villages in Liberia, which even Liberians had stopped going to see what happened. And standing in the hospital up in northern Liberia, where they were sick or not, just getting rapid testing enabled them to totally change the flow and keep hospitals from becoming transmission centers. Because that, again, is the lesson. I mean, that's basically how the Italy outbreak got started, just like with MERS in South Korea. So the whole field of point of diagnostic testing, and coronavirus was one of the ones that we needed it for, but that area didn't move. So that's one example of a game changer that hopefully will be accelerated by this. The other is this concept of distant early warning system, of warning systems. We have the weather parallel. In the last 50 years, better weather prediction has reduced weather-related deaths 95%, but satellites can't see viruses. So it's a different process. But one of the things we saw with West Africa, they weren't vigilant. They weren't alert for it because they didn't think Ebola was there. But the folks up in Germany knew Ebola was there because they'd found it there 80 years before, in the 1980s. And similarly, the people tracking coronavirus knew that there were worrisome coronaviruses in China then, but it didn't raise the vigilance. And we have a great story about how prairie dog kill-offs in the Southwest are a harbinger of plague and used seasonally by CDC to raise the alert and the vigilance around plagues. So that's innovation. On the investment side, it's the cost of investing in prevention is a pittance compared to what we're paying now. And the problem with testing didn't begin 3 months ago or 3 years ago. It started 20 years ago, in the sense that after 9/11, we created a $1 billion health emergency prevention fund. It trickled down. We had avian flu. It went back up again. We had the financial crash. It went back down again. We now have half the budget that was approved in the prevention efforts 4 or 5 years ago. We lost 45,000 public health workers over a 6-year period because of this defunding. And the $1 or $2 per person per year for every person on the planet, $7 to $15 billion over 20 years would make us a whole lot safer. And finally, advocacy. This cycle of panic and neglect happens because people can't, once the alarms and all of the vigilance has gone away, all the promises made during the panic and all the money disappears. And we now have the Global Health Security Scorecard, Global Health Security Index, as a scorecard for countries. So we can hold the countries accountable for getting safer. But there's no scorecard for the international community about whether we've kept our promises, so the countries can hold us accountable. So that's where advocacy and engaged people is really critical. So those are the 7, and I think they're as sensible as they were 2 years ago, and we have even more evidence. I mean, just unmistakable evidence. The question is whether we will stay mobilized enough to do the things that we know the risk factors are all going ahead. Scientists and public health people know what to do, and it's pretty cheap. We just got to do it.
Thanks, Jono. Later today, I'm going to be talking about whether now we can finally break these cycles of panic and neglect. It's been so frustrating, as you said. The amount of money to develop a pandemic preparedness system fit for purpose is tiny compared to the trillions that we're losing. I know that you have to go soon. Is there one quick follow-up question? We're a little bit behind time. Any quick follow-up question to Jono? Not seeing any. Okay. I know you have to go back to actually tackling the pandemic. And I have said to you, and I know that our team has said to you, that if we can support you in any way as policy analysts, let us know.
Thank you. And also, just to be clear, I meant to start by saying it's nice to be with the DGH family. I'm still with the family. Even though I agreed with Rockefeller 3/4 time. I'm like a zillion% now, but I'm still teaching and trying to stay as engaged as possible.
Yes, you are. Thank you so much, Jono. So Linfa, you are an expert in zoonotic diseases, bat immunology, and pathogen discovery. So I can't really think of a better person to help answer the question of what can we say about the origins of this virus? And also, what have we learned about zoonotic diseases from this that could be helpful for future outbreaks? There is so much speculation about the origins. It would be good to hear what we really know, what do the best available data tell us so far? Thanks, Linfa. Do unmute yourself. I know it says that the host has to unmute you, but I think you have to unmute yourself.
Okay, it's
Perfect.
working now. Okay,
yes.
Great. Okay, thank you, Gavin, and thank all the board members. So good night from Singapore. So it's close to 10 p.m. here. Yeah, so I have been studying bat-borne virus for the last 25 years. I counted it's exactly quarter of century. So as I put the title of my commentary in Lancet is From Hangzhou to Wuhan. So just give a little background to our board members. If you're not familiar with kind of the research I've been doing, is that in 1994, when I was still working in Australia, there was this mysterious virus killing humans and horses, and killing horses with 70% mortality, and killing human with 50%, but it's only two people involved, so one died. From there on, that's 94. And then we eventually sort of located the reservoir is a bat. And then 1999, there was a much bigger outbreak with a very close cousin virus, later called the Nipah virus. It jumped out from bats to pigs and then to human. So that, and then the 2003, 2002, we had the SARS virus. And we know that SARS, is a bat to civet transmission. So if you have not watched the movie Contagion, the Contagion is basically based on two viruses. It's like a combined story of SARS and the Nipah viruses. And then 2012, we had this Middle East respiratory syndrome virus. So this time we have a virus we believe also from bats, but they may jump out of bats a long time ago, and they found the second host, which is in camel. So 2012, somehow it jumped from camel, to human. And then fast forward 2019, right? We had COVID-19. Of course, everybody know about this. But in between 2012 and 2019, very few people knew about. There was a lethal virus, this time not for human, but in pig in Guangdong province. But it's a very, very lethal virus because it killed 25,000 piglets in 2 farms within 2 months. And it was a bat virus. It jumped out of bats as well. So basically, if we count that in, and then the Ebola virus from West Africa, basically we think is a direct bat to human transmission. So in the last 25 years, we had 7 major outbreaks, 6 of them affect human, but the pig virus, I think, very close to affect human, but it's not ready to jump human. So I think, it's almost a certain, I think, as Mark says, and the journal was saying, in his book, he predicted, there will be outbreaks, and I predict in 2013, I say, I can bet my lifeline. In the next 10 years, there will be another killer virus jumping out of bats and cause outbreak. So we had 2 actually. We had the pig virus, and now we had COVID-19. So the question is why bats? That's, I say, is a $1 billion question, because I think bats, as the only flying mammal, they have a very different immune system. So they have a very good balance of defense and tolerance, and that suited the virus. So virus can peacefully exist with bats, and they have been doing this for the last 60 million years. So bats and the virus are much older than human beings we have, all right? So I think, it's important, your question about how can we do, the lessons we have learned from so many zoonotic virus and mostly bat-borne viruses, can we do better? In theory, we can do better, so every outbreak like SARS, Ebola, and COVID-19, people always discussing about this banning of, wild game meat and banning of farming and the trading of wildlife. Yeah. So it's a simple concept, but if you're familiar with, the different countries, the cultural and the dietary sort of habits, I still vividly remember 2003, I was on the WHO mission, went to China. This is like July, just after the, 700 something people died of the SARS outbreak. So they actually credit for the Guangdong government. Usually in China, they don't do public opinion surveys. This time they did it. They give them 2 yes or no to say, we now know that SARS came from, wildlife and through civets transmit to human. And the civets mainly is in that wildlife market, get massive amplification and eventually go to restaurant transmit to human. So we have 2 options now. We ban wildlife farming and trading, so we reduce the future SARS-like outbreaks, or we take risk and continue our tradition. Do you want to make a guess? This is immediate after SARS, 79% of people say we will keep the tradition. No. So there's a cultural, there's economy, there's everything. So I think it's almost impossible to ban, what you call wildlife, because to me, the wildlife is a misnomer as well. Because like civets, it's now traded, it's farmed. I went to a civet farm, there are 1,000 farms in mainland China and another few hundred in Taiwan, okay? So, but when there was a SARS outbreak, WHO mission, I was a part of this 8 experts, and we went to Beijing, and there's a Ministry of Health, Ministry of Agriculture, Ministry of Science, and Ministry of Forest, because they could not agree on who's responsible for the mess they created with civets. Because the Ministry of Agriculture says, no, it's not livestock. It's not in our ministry, right? So they point a finger to Ministry of Forest because they are supposed to look after the wildlife in the forest. But they say we did not encourage farming. So it's the Ministry of Agriculture, So just that itself, I think we are not ready. Unless, internationally we have a One Health approach, and policy-wise, if we put the act together, I don't think we can solve that problem. So now just to last point about this COVID-19, where it's from, I always say, ask the media and the policymakers to be patient, because I always use SARS as example, right? So COVID-19 and SARS are the 2 opposite examples. For SARS, we knew within 5 months to say civets in the market carry the same virus and transmit to human. And then my team with a collaborator from Australia, USA, and China, eventually that 18 months later, we had enough evidence to say it came from bats. Right. And it was led by serology. So I'm going to come back to serology that Mark mentioned at the very beginning. So now what we have with COVID-19 is the opposite. What we have discovered in the international community is the most related virus, genetically 96% identical, the virus is from bats, okay? But we miss this intermediate, the equivalent of civets for SARS, we still don't know. And also, scientifically that people argue that you don't need an intermediate host like the Ebola virus, you can have a bat-to-human transmission directly. But with my 25 years of study, I think it's very unlikely. And also we have evidence because that Huanan seafood market in Wuhan, that's the market. Initially, the alarm bell rang is because the first cluster of 48 patients, 70% of them had a direct link with the market.
Yes.
So without any doubt, I think the market play a role there. But whether the virus was introduced by the animal to the market, or now people believe there is other means of transmitting to humans. So there's a human to animal transmission in the market, followed by the amplification in some of the animals in the market. So now I think we know now in the media, now it's really like in the New York Zoo, we know a tiger is infected. So that's a reverse zoonosis. That's a human to animal transmission. In Wuhan now, they sampled over 100 cats, and 10% of them have neutralizing antibody. So really strong evidence to say the cat has got an infection. And then in Hong Kong and Belgium, I think now we have evidence of dog. So I don't want to cause a panic to say, these are the major sort of human to animal transmission, but I just want to illustrate it is possible to have a reverse zoonosis. The human give the animal the virus in the market, followed by the massive amplification and go back to human. Okay?
Got it. Oh,
so the last point is about serology. So I think Mark opened that to say, in the human sort of study, COVID-19, now we're at the stage, whether you call it a herd immunity or you want to get an immunity passport, to the people to go back to society. As he says, we don't have a reliable test right now, because the most reliable test, the gold standard in virology, is virus neutralization. So you basically have to demonstrate a human serum has antibody which can neutralize the live virus and prevent it infect a cell. That has to be done in a BSS3 lab and takes 4 or 5 days. So my lab, just patent, we have a patent where we developed a surrogate neutralization test. Now we can do it in ELISA plate and 2 hours, and we get neutralizing antibody. So what we're hopeful is that, but still, I think the second question, one is you can quantitatively measure neutralizing antibody. But secondly is whether neutralizing antibody is a direct correlation with protective, because it's T-cell immunity and things like that. So I think the science still need to be done, And that the other important thing is our neutralization test is species independent. So our same test can be used for human, for cat, for tigers, for pangolins, for bats, you name it, okay? So we're very excited, we try to help with the human control side, is try to have a very rapid neutralization test that we can mass produce and takes 1 hour. And the same test now can be used to trace that mysterious animal X, which might be involved in the transmission, because we need to find that to prevent future outbreak. And with that, I'd like to thank everybody, and Gavin, back to you.
Thank you very much, Linfa. I've got 7 million follow-up questions, which I won't pose to you right now, and I'm sure everyone else does. I'm going to try and get to questions in about 5 or 10 minutes. Yes. Chris, so you have been a remarkable pioneer in testing treatments during outbreaks. It's actually quite a technical challenge. We obviously want a rapid answer on what's working. We don't necessarily have the same time to play with, years and years of doing these perfect trials. And you really have become a pioneer of doing these new kinds of trials, particularly during Ebola in West Africa, 2014 to 2016. Tell us where we are at with treatments. Mark McClellan right at the beginning talked about how we are clearly going to need therapies. That's not just to reduce death rates, but presumably antivirals could also prevent transmission in the way that HIV drugs prevent transmission. Where are we at? What is the status of those treatments? Which are the most promising? And then how can we test them in ways that we can still get an answer on whether they're safe and effective, but we can speed up the time?
Yeah. Can you hear me?
Yes.
Wonderful. It's good to join everyone this morning. I'm particularly pleased to be on the panel with many of my good friends. I'm sorry, Dr. McClellan had to drop off. Actually, by background, I'm an infectious disease clinician, but also a medical microbiologist. So most of my research actually focuses on diagnostic tests. And Linfa and I have worked on projects over the years looking at improving diagnostics and doing surveillance for the emergence of novel pathogens over the years. And that's kind of where my heart lies. However, during these events, I have found myself working more broadly in different research capacities, which is always important. I believe. There are some similarities to what we experienced during Ebola, where we had no therapies at the time, and we found ourselves trying to repurpose a large number of drugs and get them assessed for effectiveness against that particular virus. And that has led to actually some the development of new therapies as well. And that'll kind of play into what I'll end up talking about. I am overseeing kind of a large number of research efforts at Duke. And I'm going to walk through kind of the current therapies and talk to you a little bit about where Duke is on those therapies. But I thought I'd start by mentioning, our basic understanding of the pathogenesis in a real simplified model is you have a period of time of likely minimal or asymptomatic infection, followed by a milder course of illness, which has actually, in my experience, great diversity. Some people have GI illness, some people have respiratory illness, some people look like they have the common cold, some people lose their smell. It's actually quite diverse in the people that I've taken care of or engaged with over the course of the last several weeks. And then for an unlucky 15 to 20% progress to more severe illness and are hospitalized. Another 5% of those go on to intensive care requirements, and then a smaller percentage, varying depending on the capacity to care for folks, largely die. And some of that, those deaths are undoubtedly occur because our main therapy at the current time is supportive care. And this is the whole point where we've talked about the flattening of the curve and outstretching our current capacity to provide, excellent supportive care, which, is the best thing we can do for that smaller percentage of folks who go on to severe disease. But that transition point between the milder illness and the more severe illness is hard to exactly pinpoint, but seems to occur somewhere between 7 and 10 days. And there is ongoing viral shedding throughout that period, but there is a marked transition to a more inflammatory state that seems to take place, and people go on to develop what's called acute respiratory disease syndrome, ARDS. And so that means there are a couple of different opportunities for our therapies, going after the virus as well as going after that inflammatory state, depending on the time you are in the course of infection. So I'll start with the repurposed drugs. The antivirals that we talk about, the one that's the leading candidate and that you hear the most about is a drug called remdesivir, which is a Gilead product, which targets the virus's replication. It has the best science behind it supporting its potential utility, in that it's been demonstrated to have some effectiveness in animal models that Sallie was referring to earlier. Everything else at this point is based on effects in a test tube, and that's proven to be quite problematic in other disease therapeutic developments. So it has the greatest likelihood of success amongst the candidates, and so appropriately it's the most field forward in its utilization so far. There are studies that are supported by Gilead itself that have taken place in China. They're ongoing. There are studies for moderate and severe disease here in the United States supported by Gilead. But the main study, and I'll come back to this when I talk about designs that is using that particular drug, is performed or is sponsored by the NIH, and it's a specially designed trial called an adaptive design trial, where this is the first therapy that's being utilized in that, and it's randomized against standard supportive care. And that study is about 2/3 to 3/4 complete for its initial enrollment, but they just enlarged the size because its continuation and the analysis is going to take a few more weeks, and they want to continue to enroll people in that study. And Duke is a site for enrollment in that study, and we've in fact enrolled about 5 individuals into between 3 and 5 individuals right now into that study. I'm not exactly sure where that stands. So after that, there are a number of, pardon my wife coming through. there are a number of other potential drug considerations that are not as far along, that are not traditionally considered antivirals, and we've heard a lot about these in the media. And one is hydroxychloroquine, which is an anti-parasitic as well as an anti-inflammatory, and it has been paired with an antibacterial azithromycin that many of you are familiar with when you have kind of a bronchitis or a community-acquired pneumonia, often used in treatment. Didier Rouault and a few others around the globe have been major proponents of these drugs, either alone or in combination. And again, these are based on the performance of those drugs in reducing the infectivity of similar viruses that we've talked about, the MERS and the SARS-1 basically in the test tube. And then there are some relatively conflicting data in clinical studies thus far between some early Chinese data as well as out of France that are as yet not fully, or again have kind of competing results. Though we have a number of studies ongoing to evaluate those, the first of which is we've had a lot of encouragement just to use hydroxychloroquine as a therapy, but most of us in clinical medicine are uncomfortable with that and have moved to implement a trial to test hydroxychloroquine against, with or without azithromycin against placebo, and that study is moving forward here locally and is led by a PI, Jason Stout, and in fact has been adopted throughout, is going to be adopted through by a number of Veterans Affairs facilities. So that's an interesting approach to evaluate those particular drugs. Those hydroxychloroquine in particular, given its relatively, it doesn't have a broad list of side effects, and in the right populations is well tolerated. So it's being considered for a prophylactic therapy in the setting, particularly for healthcare workers. And there are a number of these studies taking place. Gates is sponsoring a 2,000-person study in Washington. Mayo has an interesting design where it's allowing people to enroll from around the country into a study, and the drug is provided locally through a network called PCORI, which Duke is a leader in. We're about to launch a 15,000-person study for healthcare workers, including here on site, using hydroxychloroquine for a month during this peak time of disease transmission, to try to assess the impact of hydroxychloroquine in a controlled trial. And so that's kind of the ways we're attacking the virus right now. And then there's a long list of potential of antivirals. And so then on the other side, there are some approaches looking at how do we impact the immune response. And there are a number of anti-cytokine therapies that are being looked at. There's a long list of them that attack different points in the inflammatory cascade. Tocilizumab is the one most people hear about. And then there's a few others. I failed to mention kind of a very old approach to therapy on the antiviral side, and that is actually harnessing those survivors amongst us. And this is another part of or another approach we're taking part in here at Duke. The idea there being as was alluded to, people develop immunity. It correlates with a good serological response. Linfa mentioned the importance of neutralizing antibody. That's specifically what we look for. So we have a study where, in my group, where we're enrolling a large number of survivors and are looking for the presence of neutralizing antibody. Those individuals would then be referred into a central center for like a blood donation center where the antibodies would be pulled off and used as a therapeutic. We call that convalescent plasma treatment, and that's also been in the news a lot recently. Nathan Thielman is leading the one of our leading investigators, and the DGHI is leading the implementation component of the convalescent plasma study. And then you've got a kind of